So we good with this case, guy? Everyone good? No confusion? Vâng, you look like you still have a question to ask. I can't see the safe face.
Really? Oh,
Vâng, are you still
I don't. I want to know about the fractional. Fractional.
Nope. You want me to roll up or down?
Up.
Okay,
Fractional
up.
excretion of sodium. Yeah.
Of
What does
sodium,
it mean?
fractional excretion of sodium.
Yeah.
Okay, what does that mean?
So it's kind of percent of sodium concentration in the urine per the concentration of the sodium in the serum.
Okay. What does it? What's the normal fractional excretion? 1%. 1% is really normal to me. You think? Think it's normal?
Yeah. 1% is normal.
Okay, good. In hypovolemic hyponatremia, if the fractional excretion is more than 1%, it's telling you is what? It's renal losses. So which is a renal cost. If the fractional excretion of sodium is less than 1%, it's extra renal cost. It should tell you if it's the kidney fault. Okay? So if it's less than 1%, it's a kidney problem. No, it's not a kidney problem. I'm sorry, scratch that. It's something else, not the kidney. Okay? If it's more than 1%, then it's a kidney problem. That's all it means. Okay? I'm using the guidelines to tell you guys that, so sorry about earlier. If the fractional excretion of sodium is more than 1%, it's the kidney problem. Okay? Something affecting the kidney. Or it's the kidney itself that causing this. If it's less than 1%, it's something else beside the kidney, like you losing diarrhea, stuff like that. But this is 1%, so it doesn't really help us much because it's not high or low, it's just 1%.
That's okay.
So that's why I don't pay attention to that at the moment. But maybe the next case. Here we go. We got 0.5. All right. Somebody read the case. Simple say is Nguyen read the case last
Okay.
case.
I can read it.
Okay, you can read it? Okay, let's read it.
Yeah. 65 years old male comes into your emergency department with a chest complaint of headaches and dizziness for the past 24 hours. His vital sign is 130, 90, and 98 Fahrenheit. The heart rate is 18 beats per minute with 96% oxygen at room air. Her BMI is more than 40. Physical examination reveals that moist mucous membrane and normal skin turgor. He has JVD and pulmonary edema, is noted on CHO.
Oh, wow.
Her
Sorry, don't ignore that. That was a typo. It's supposed to be his.
her
That was a typo.
okay. His laboratory value reveals that sodium was 120, potassium is 4.0, blood glucose is 90, blood urine nitrogen is 28, urine sodium is 9, urine osmolarity is 150 milliosmolarity per liter. Fractional excretion of sodium is 0.5%.
All right. So before we read the question, can you just guess what this patient has? Without even do anything, I already figure.
Like her BMI.
You know,
Yes,
Bad.
he got.
You can say that. It's okay. We say that all the time in the hospital.
He
She's
has
a little bit
GVD.
obese. Not obese. She's just obese. Okay. What else? What else does she has?
More mucus membrane. JVD.
JVD. What's
Pulmonary
JVD?
junctional vein
Jugular venous distension. Technically, water is here.
distension. Yes.
And you see that the jugular vein, which is right here, is distended, which is filled with fluid. Okay, so something going on
Yeah.
in the heart.
Pulmonary edema.
Pulmonary edema. What's that mean?
Sulfoid.
Yeah. Technically, when you see an X-ray, you see a tons of infiltrate in the X-ray. That's pulmonary edema. Water rushing the lungs. Okay, that's what it means. What about mucous membrane? Is it moist or dry?
It's no more.
It's wet. Was she really wet, right?
Yeah.
That sounds wrong, but I'm sorry. That sound kind of wrong. If I'm on OB and I say she wet, that's a problem. Yeah, that's kind of sound wrong. But vital sign. Why you guys keep putting out vital
Vital
sign?
sign is hypertension. Diastole hypertension. Diastole hypertension.
Okay.
Oxygen.
90.
96 is a little bit low, a little bit.
Heart rate is 80 is normal.
Heart rate is normal. Temperature is normal. I would say vital sign a little bit high. Well, it's considered pre-hypertension, but probably just carry one, but it's not really that high. I'm 130 and 90 all the time, so I don't feel anything.
But maybe I think it can be normal in his age. Maybe.
Yeah. 65, 130 over 90 with obese BMI. Yeah, that's really tough.
That's the.
And is this acute or chronic?
Acute.
Acute. 24 hours. All right, I will ask Vân to calculate my serum osmolality. But even though we may know what this patient has, let's follow a protocol that we've been using. Let's calculate serum osmolality. Sodium times 2, 120 times 2, 240. Plus 28 divided by 2.8. Okay, that is 10.
Yeah.
90 divided by 18. And what's that?
255.
200, 155. Wait, 200 what?
55.
55.
255.
Okay. All right. Was that low or high?
No.
Again, it's lower than 280. Okay. So what she have? Say the word.
Hypotonic.
Hypotonic. Hyponatremia. Make sure you say that word like 10 times or something. Oh, I hate typing it out. Let's just hypotonic. Okay, good. Make sure you say that word. It's a magic word. We use that. All right. Now, what about urine sodium? Is urine sodium high or low? What's the value that we use?
It's a bit low.
20.
Compared to 20.
Okay. This is like math all over again. See, sodium is like playing with math. If you don't like math, you probably don't like sodium. Okay, urine osmolality. 150, was that fine?
150.
There's more than 100 for sure. So 150 is more than 100, telling me something.
Hyper.
What about fractional excretion of sodium? Was that less than 1% or higher than 1%?
Lesser.
And remember what I say earlier is less than 1%. What was that?
It means there's some problem outside of the renal.
There's some problem outside of the kidney. We call that pre-renal. Pre is before, renal, kidney. All right. Now let's look at the patient history. What can you tell about? Is she wet or she dry? That's I'm concerning with that.
She's very wet.
Very wet. Okay. There's nobody dry HJVD. Okay. Nobody dry have pulmonary edema. Okay. So she's very wet. All right. All right. I will erase all of this. So we got this in our head now. The question is, what's the most appropriate management right now? What do you want to do? Would you give her more fluid if she already that wet? No, right? Right, Vâng? You give her more fluid? Now you're a doctor. Now, Vâng, you're a doctor. You tell me what you're gonna do.
Well, I will give her furosemide.
You will furosemide.
Yeah, because
Okay.
because she's in wet condition and she has pulmonary edema.
Okay. Good.
And the concentration of potassium in the serum is normal, so we can use the furosemide.
Good.
Yeah.
Well, so why don't you give her saline? Like, why don't you give her more fluid?
I think she's wet. The fluid is not necessary.
Okay. Yeah.
Yeah.
Well, we don't do A or D because she already wet. We only do D if it's true, like other cause of hypernatremia, which we talk about next week. Okay. We only use it when something else we talk about next week. Hydrochlorothiazide is also diuretic. Why don't we use it? Kind of weak.
Yes, it's kind of big.
Weaker than furosemide. Okay. And she is currently have headache and dizziness, so you want to control her symptom quick. Furosemide is just good.
Okay.
Of course, there are other stuff to do like oxygen and stuff, but we just focus on giving her fluid first. What about spironolactone? Also really good diuretics. But again,
It's wet.
you want to be quick. So furosemide is the quickest diuretics in all this class. Plus, we usually use spironolactone if the potassium is kind of low. But right now the potassium is normal,
No.
so
It's no more.
yeah, so we use spironolactone in this case. So out of these three diuretics, furosemide is the best choice to use if your hospital available. Okay?
Yeah.
Alright. Good job! It's tough. It's all about calculation and stuff. So when you guys go out there in clinicals and you see a problem, always calculate those things. And also patient history is important. Dry or wet. That's all. The rest we talk about next week. So here's the algorithm that looks terrible on up to date, and you guys probably can't see that. So ignore this slide. You guys can always go on up to date and look at it. This is very calculated and very detailed. Even I don't remember this. This is a more simpler way. This is very simple. Calculate serum osmolarity. That's what we do. Low, hypotonic hyponatremia. High, hypotonic hyponatremia. Normal, isotonic hyponatremia. Okay, and then you just follow down. Okay, patient have hypotonic. Then we look at the volume status, which means the vital sign, the jugular venous distension, the skin, see that, all that, mucous membrane. See that we already discussed about all the patient wet or dry. Okay, if the patient look wet, like the previous patient, then we look at urine sodium. Okay, high or low, fractional excretion of sodium, high or low, then we determine that. So because earlier the patient, we follow this algorithm to the heart. So first we do that, and then we look at the vital sign, the JVD, the wet mucous membrane, wet skin turd, so we go this route, okay? And then we use this. She was 9, so 9 is less than 20, so we go to heart failure, cirrhosis, nephrosis, hyponatremia, but it doesn't look like she have nephrosis or cirrhosis, because could be, but who knows? We just want to know if she wet or dry. So we know that she in this category, so we treat her with diuretics, fluid and sodium restriction. Okay, that was the second patient that we follow this algorithm. The first patient we use this algorithm right here. Okay, actually, I think it's one of these. I think it's this one. Sorry, because she looked dry. She's not euvolemic. So the very first patient, we do this again, but the patient looked dry. Patient looked like she dehydrated, so we go to hypovolemic. Hypovolemic means low water. Hypervolemic means high water. Euvolemic, that's a very complicated issue that we talk about next week. Okay. Euvolemic is very complicated. So what I want you to guys do before next week is review this chart whenever you have time. You don't have to do it right now, but I think it's very helpful to know this, because this may give you a quick rundown of what's going on with sodium, because again, sodium is water. If you know sodium, you know almost everything in internal medicine. Because literally that's all we do with internal medicine. We deal with electrolytes. Alright, let's see what else. I think I have one. Okay, yeah, this is another simplified, very simple chart. It's just telling you low sodium 135, the serum sodium osmolar that we talk about. Okay, true hyponatremia. Then look at the patient. JVD, there is a done. Dry mucous membrane, volume down, something going on. Okay, then look at urine sodium. Then look at intrarenal, done. This is simpler than the previous one, easy. I give you guys 3 different algorithms, so you guys can use whatever. This is the treatments, very simple, just for your information. So Vung, you're not on clinical yet, but will be soon. Maybe not important. Focus on the test first. When you're on clinical yet, when? Yeah, so this is fun. This day too, this is fun, right? Sodium is fun, right?
Not really.
Yeah.
Not really, but it's very fun once you know what's going on.
Yeah.
So always follow the algorithm. I'm a kind of doctor that just use algorithm all day. To me, this is the guidelines. I don't know why we should not follow it. We don't have anything to think about besides just calculation. Okay, really, just do a thinking for us. Just know the algorithm. You may need to remember this, but you may not when you practice. Because when I practice in the future, I should print this chart out and put it on my table.
Mm-hmm.
Yeah. Okay. So that's all about today. Any questions so far? I'm quicker than 2. No, I'm only doing an hour or 2.
I heard that. I heard that.
Oh, you come back.
Sure, I didn't miss any moment. So I heard that. Yes, I will.
Yeah, whenever
Okay.
I talk bad about her, she just appears. So
Oh no, the problem is I use phone. When you guys start, I am on the way to moving a lot, so I cannot use laptop. But now I sit down and then I can see you guys. So I believe today you guys have really effective talk, and Mr. Leon give a lot of information,
Your baby's
and
playing.
that's really important.
So maybe.
Yeah, but I think that's very good instruction, right? Do you guys agree with that?
You guys all know about hyponatremia a little bit now. There's still a lot to talk about. Like, let's do this side of the algorithm. Let's do this side. So technically,
Yes.
we finished the left and the right side. Next week, we focus in the middle. Okay,
Mm,
because middle is hard.
yeah,
I'm telling you.
harder.
Okay.
Mm.
Way
But-
too hard. But it's good. Now you guys can know a little bit about hyponatremia. That's all I hope to gain.
Sure.
Any question? Would any question per se? Any question?
So I have a question about
Yes.
the second patient. She have a kind of increased extracellular volume, but she also have a hyponatremia, right? So we use a diuretic to treat this patient, but we still have to pay attention to the sodium concentration. So
That's right.
so
That's right.
Yeah.
But it's probably just fake hyponatremia because the volume in your body probably too much. That is dilute all the sodium.
so should we check the sodium concentration regularly to make sure
Yeah, we should.
not
We should do that. That's good. We should do that. When we use furosemide, we should check her electrolytes. Okay? Check it. That's good. That's a good point. Yeah. Don't walk away from your patient when just giving treatment, okay? This could be fake, but this could be real, so who knows? Okay? So we don't know that until we get rid of all the fluid in her body and then we check her electrolyte measurement again. Then if her sodium is increased by that time, then we know it's probably from the heart failure, probably from overload. Okay?
Mhm.
But the fact that her urine sodium is very low telling me that it's probably fake because her body is keeping all the sodium in there already, so it's trying not to excrete that. Okay? But always check your patient electrolyte after you do something because it may change. Every 1 hour it may change, every 6 hours may change. Okay?
Yeah.
So that's a good
Then
question.
Electrolyte disturbance. Yet electrolyte disturbance very fast to
Yeah.
bring the effect, right?
You know, like this is just a side question. Do you know what happens if you correct sodium too fast?
it may cause the myelolysis, right? The polylysis.
Central protein myelinolysis.
Yes.
So
Good job.
it's caused issue with the brain. It's called central protein demyelination.
Mhm.
So technically, your pons will be destroyed technically, and it's caused something really cool, not for the patient. It's really cool called I forgot what the name of the syndrome, shut-in syndrome or something like that. Technically, patient know what you do.
Block. Called like what's the block?
Technically, patients know what's going on surrounding them, but they can't respond. So your whole body is shut in.
We call like block. We have start with the block.
I don't remember that.
Yeah, let me check it.
Anyway, it's just a side information. Lock-in syndrome.
Yeah, block is okay.
Not lock-in, lock-in syndrome.
Locking, yeah, sorry. Locking syndrome. Locking syndrome. Too fast.
Okay.
Okay, don't correct it too fast. I don't know the rate. If you ask me about, I don't know the rate, but I'll look it up next week. I'll let you guys know.
So I
But I
have
don't
some more questions, please.
Okay.
Yeah. So I know that three types of diuretic can affect the sodium concentration, right?
Mm-hmm.
But what type is the most effect on the hypo sodium concentration, hyponatremia? I mean, it will lower the sodium concentration the most in three types of diuretic.
Okay, that require a little bit physiology. So let's draw the kidney out.
Yeah.
So this is your glomeruli. Okay. Because once you understand this, you understand what doing the most. All right. So this is our descending loop of Henle. This is our ascending loop of Henle. What's this part called? I totally forgot, but it's got something over here. Sodium, potassium chloride channel, right? Sodium, potassium chloride. Okay, it might do something. I don't know.
Distal.
Okay.
Distal.
This is sodium, just sodium potassium channel, regular one. Okay, so hydrochlorothiazide affecting that. Furosemide affecting this. Okay, what did you think it will lose more sodium? Let's say sodium and water flow to the kidney, and then it's get affecting here by furosemide, so it's going to keep flowing here. Okay, it's flow more, right? Furosemide make you lose more sodium because when if you use hydrochlorothiazide, the sodium already reabsorbs somewhat when they travel through all of this, and then hydrochlorothiazide only affecting this part of the kidney, so it's affect in the lower part of the kidney. Okay, this affect in the higher part, so it's more potent that way. So furosemide will cause you lose more sodium quick.
Mm-hmm.
Yeah.
But if you use furosemide, the sodium may have chance to reabsorb in the conducting.
That's true.
Conducting.
That's true. That makes sense too, because there's a sensor right here that sends the sodium absorption.
Yeah.
Yeah. However, the furosemide not only affecting the sodium, it's only affecting the osmolality as well. That's why it's more potent. It's causing the osmolality around the surrounding area, the kidney right here, to be increased, I think. Yeah, to be increased.
Yeah.
So, yes, furosemide is more potent. I'll look it up more next week to explain it to you in case this is not clear, but I will look it up.
Mm-hmm.
Spironolactone is like way down here, so like spironolactone is like down here.
Mm-hmm.
That's why it's trash all the potassium as well. It's keep all the potassium for you. I will look it up next week. I have really good cartoon videos on diuretics. If you guys want to learn pharmacology using cartoon, I have the videos. It's awesome.
Yeah.
It will teach you everything about diuretics. We call it sketchy pharmacology. If you guys know about sketchy videos, I use those to learn pharmacology. Yeah, but I hope this clear up somewhat. But next week I will talk about this again, in case you guys don't remember. Or after hours, I will explain. I will draw the whole glomeruli out and explain it to you because I love this stuff. Drawing is passion.
Thank you.
Okay. Any questions? Any more questions? Vâng, you have question?
No.
You look confused. You always look like this.
Wait.
Whenever I see you look like this, it's like she must have some questions. All right. If you have no more question, you're free to go. It's done. Thank you for joining. Most people like cancer, so that's why they don't join today. But electrolytes is important.
Yeah.
I don't know why. Actually, in the previous time, we think like the cancer is too hard for people, and then that reason
Yeah,
why
they
we
say cancer is too hard. Now I'm doing a little bit harder. So that's why everybody left.
Yeah.
Actually, Mr. Hoang, because he interested in cancer. That reason why he didn't join today.
Well, I'm only
If
do
we,
sodium 2 weeks, and then I return it to you so you can talk more cancer, and then we return with potassium.
you want like this?
Oh, I love anything that's not cancer.
Okay. No, I think let's just start with the series of this electrolyte is
Yeah, I
better
will
because
finish the series. So next
yeah,
week we talk about electrolyte part 2,
Yep.
which is sodium part 2.
Yep.
That's sodium is too much to talk about.
mm-hmm.
Okay.
Yeah, because it's also continuously to memory a lot of things like because
We're gonna
no
keep
one's into.
calculating, guys. So don't forget to calculate serum osmolarity.
That's very important. Very important.
Very important. Because
Yeah.
teaching you guys, I know how to calculate too. So thank you.
I also had formula like calculation like this, but
Nobody
what can we
likes math.
do?
That's why I go to medical school. I don't like math. Why have to do all this talk again?
Not my weakness.
I know that when you thi đại học, like you have to do math, bio, and chemistry.
Yeah.
In America, we don't take math in consideration when you go to medical school. There's no need to know math. Yeah, but yeah, potassium there will be calculation. Calcium there will be calculation. So be prepared. There's a lot of Make sure you have calculators. Okay, good job. We conquered part 1 of sodium today. So awesome.